Great, perfect. Thank you very much for having me come. Lisa, thanks for the invitation, and thanks to everyone that's organized this Trauma Education Day. I'm going to present on a patient that we had the fortunate opportunity to manage last year. The case really stood out as one of those sort of amazing or memorable cases because it really demonstrated a number of key features that are important for us as healthcare professionals in the ICU, namely teamwork, cooperation, leadership from all respects and regards, as well as communication, which I thought would be one of the focuses of the talk. But just to start off, I really wanted to just present the actual case presentation to give you a sense of exactly why I'm here today. So this patient, we'll call her OB, is a 31-year-old female, G5P3T3L3, who was actually a military wife in Camp Pendleton. We received a call from one of the surgeons there with regards to the patient wanting to transfer her to a higher level of care, specifically to our SICU. The patient had suffered a massive postpartum hemorrhage. Essentially, the patient was brought in 24 hours previous to her actual induction, and at that time was 41 weeks, so about a week overdue. She underwent a standard vaginal delivery on March 12th at around 3 p.m., and almost immediately following her delivery, she suffered a significant hemorrhage resulting in shock and was expediently and urgently rushed to the operating room. At that time, they initially started just from down below, attempting to get hemorrhage control from the vagina. They actually found at that time she was bleeding profusely from what they believed initially to be a cervical laceration that they attempted to repair with sutures. The patient continued to deteriorate, and at that point they called in the two OB gynecologists at the time, called in two other staff general surgeons, at which point they proceeded with an attempted fan and steel incision to perform a trans or supracervical hysterectomy. Unfortunately, she continued to profusely bleed, and as such, she underwent an exploratory laparotomy. She did eventually undergo a transabdominal hysterectomy, and at that time, they also performed bilateral internal iliac artery ligation. They packed the patient's pelvis, left her open, and essentially by the end of it, the baby boy, which was delivered safely, was in the NICU. She ended up losing about 5.5 liters of blood during that initial procedure, mainly as a result of a uterine laceration. In fact, she had about a 10-centimeter laceration to her posterior uterus, which was the major source of hemorrhage. She ended up undergoing a massive transfusion. In Camp Pendleton, she received about 26 units of blood, almost an equivalent amount of FFP, and as you can see, they did perform a one-to-one type of hemostatic resuscitation, which is what we're doing for patients that do arrive in hemorrhagic shock in the trauma setting. She also received a number of other blood products and quite a bit of crystalloid as well. So obviously, when you hear that a patient has received this type of resuscitation, a number of things start to go through your minds. And of course, or not of course, unfortunately, her actual intraoperative course was complicated by about a 5-minute PEA cardiac arrest as well. Essentially, she arrived to us, and we were there ready to meet the patient. There was, a trauma surgeon, as well as two very experienced trauma ICU nurses. Dan and Laura were there, as well as Jen. And immediately upon transferring of the patient from the transport gurney to the bed, she was once again in a second PAA cardiac arrest. And the reasons for this are multiple. Number one, she ended up sustaining essentially a class 4 hemorrhage, and we'll talk about the different classes of hemorrhagic shock. She had a severe metabolic acidemia, and I think her initial pH demonstrated a base deficit of about -13 and a pH of 7.0. At the same time, she had other significant electrolyte abnormalities, and she was severely hypothermic with a temperature of 92 degrees Fahrenheit. So just to quickly review our sort of classification of shock, this is from Gutierrez et al. In Critical Care 2004, and it's a very nice demonstration of the sort of classical American College of Surgeons Committee of Trauma classes of hemorrhagic shock. And essentially what we have on the y-axis is our O2 consumption as a function of O2 delivery. And of course, whenever we talk about shock, really we're talking about that fine imbalance between tissue oxygen demand and delivery. As soon as the body's ability to deliver oxygen decreases below the demand of the tissues, essentially we have a change in terms of aerobic glycolysis to an anaerobic form of metabolism with accumulation of lactic acid and other sort of metabolites. But essentially for this patient, she was really in this class or stage 3, stage 4 form of hemorrhage. And usually we equate that with more than about 30 to 40% blood loss, which is about the time you would start to see things such as tachycardia, hypotension, mental status changes, etc. So we were already sort of quite far behind the 8 ball. Again, the big problem with shock, hemorrhage, and massive transfusion comes down to this bloody vicious cycle that we talk about in trauma. Patients sustain significant tissue trauma, which may result in hypoperfusion and shock, which of course will eventually lead to acidosis. The problem with acidosis is it begets coagulopathy, and as such we start to transfuse patients' blood and blood products, plasma, and that tends to lead to hypothermia. And again, the 3 factors really tend to perpetuate one another to the point where we have death of the organism or patient. This is a bit more of a complicated cartoon sort of demonstrating the sort of more modernized form of the bloody vicious cycle. But the whole point here again comes down to a significant physiologic insult complicated by severe physiological derangements and transfusion as well as resuscitation measures complicating the issue. In the SICU, essentially the patient required ACLS protocol for about 5 minutes and did have a return of spontaneous circulation. We did, again, initiate a massive transfusion here at UCSD, again, starting with 1-to-1 PRBC to FFP resuscitation, really minimizing crystalloids and only using them as a temporizing measure until blood products were available. She ended up receiving 2 doses of FEBA, which is no longer on our formulary, also known as prothrombin complex concentrate. As well, we administered tranexamic acid. And recently there's been one of the largest prospective randomized multi-institutional control trials in trauma looking at tranexamic acid on outcomes in terms of mortality and requirements for blood transfusion. And if administered early, it's been demonstrated that this has a statistically significant mortality benefit. It's not currently part of our massive transfusion protocol, but we are considering implementing or including this as part of that protocol. I guess the one thing that was quite different in this patient's resuscitation is that because she was so severely hypovolemic and in severe hemorrhagic shock with an open abdomen, at that point we decided just to rip her back off, and we actually performed a manual compression of her intra-abdominal aorta, which was a very successful maneuver in terms of helping with her resuscitation, and mainly for improving and maintaining cerebrocardiovascular circulation and perfusion. And of course, active warming measures to help reverse the hypothermia. That's just a sample of her initial blood work, again quite acidemic, coagulopathic, and evidence of a lactatemia consistent with shock. We did continue aggressive resuscitation in the ICU for a couple of hours, and once we were able to reverse her coagulopathy, warm the patient up, at that point we decided to bring her back to the operating room. During this case, she ended up losing a couple of liters again of blood, and we performed a completion hysterectomy with adequate hemostasis. She ended up receiving quite a bit more blood and blood products. Post-operatively, the patient did quite well. She was brought back to the operating room on her second post-operative day for a washout of her abdomen and definitive closure. She was actually, despite all that resuscitation, was extubated successfully and without complication on post-op day 3, which is, again, quite different from the typical patient that would normally receive liters and liters of crystalloids, specifically saline and Ringer's lactate. And there really does seem to be a decreasing incidence and trend, specifically with regards to the development of ARDS in these patients who don't have a primary pulmonary pathology. And post-op day 7, interestingly, the patient was actually complaining of post-traumatic stress disorder-like symptoms. And this is something that I wanted to talk about a little bit. This is an actual quote taken out of the psychiatry consultation note, and it reads, "Over the last few days, she has been having flashbacks about 3 times a day of the same bright light she witnessed at the time of the trauma. She states that she wakes up startled and anxious. Sleep is somewhat fragmented because she wakes up anxious and worried she's dead. She states that she and her husband try to prevent her from discussing her hospital course so she does not have to relive the event and get stuck in another flashback." Fortunately for the patient, she was discharged home on post-op day 12, and psychiatry felt that she did have enough emotional supports in place that she did not require initiation of any types of medications. So with all that said, actually, really, I haven't to this point talked about the really interesting aspects of the case, which revolved around the patient's resuscitation. At the time that the patient was in PEA, cardiac arrest, we were actually talking to the patient as a means of trying to coax her to come back to us. And she was not obeying commands or able to communicate in any way, shape, or form. You would ask her to squeeze her fingers, show you 2 fingers, wiggle her toes. She had absolutely no ability at that time to be able to communicate with us. But what we noticed was her eyes were kind of spookily open, and it almost looked like the patient was staring at us. And so we sort of looked at the patient, talked to her, and asked her to try communicating with her eyes, and in fact, she could very clearly communicate yes, no, 1 blink, 2 blinks, and was completely aware of everything that was happening to her during the actual resuscitation. During the transport, actually, if you talk to her, she remembers being on the chopper, she remembers arriving at UCSD, she remembers the resuscitation, amazingly. And that was really a profound experience for, I think, everyone involved. The day that she was extubated, which was post-op day 3, she actually did remember us and myself at the bedside, and it was very emotional when she started crying and actually saying, like, "Oh, I absolutely remember every word that you said to me during the resuscitation." And I thought that that was a very heartwarming and important sort of message for us. And so I briefly just wanted to quickly talk a little bit about communication in the ICU. And of course, all of us have done the Life Wings project and course, so I don't want to focus so much on communication between patients or between physicians and professionals, but really more about communication between healthcare professionals and patients. And really, when you look at the medical literature, specifically the nursing literature, I mean, it is scattered with tons of different reports and studies looking at improving communication in the ICU between nursing staff as well as patients and their families. And I'm a little bit embarrassed to say that when you actually look at the medical literature or physician literature, it is scant. Even going back to the 1990s till now, if you were to look on PubMed or do an Ovid search for communication in the ICU, you're going to end up getting back less than a couple hundred of hits. And of those hits, really, there's a lot of talk about end-of-life communication and improving sort of shared decision-making amongst healthcare professionals and substitute decision makers. But there's really nothing out there about how we as physicians, and again, I'm not including nurses because there's a lot out there, but how we as physicians can improve our ability to communicate with patients in the ICU. I don't know if you've experienced, but I've seen it a lot. We have a lot of young as well as older physicians who come in and assume that because a patient is sedated, receiving analgesia, and intubated, that they're not here or part of what's going on in everyday daily life. And very commonly, you'll see patients come into rooms, lift up people's gowns, start examining them, flipping them, putting in lines and invasive monitors without even saying a single word to these patients. So I really think it's an area that all of us really do have a responsibility for in terms of educating our colleagues especially sort of junior house staff, in terms of the importance of communicating with patients. Because as you've heard, I mean, even dead patients in some situations apparently can hear and understand what's going on in their physical environment. So when you actually look at the definition of communication, it's the mutual exchange of information between two or more individuals. And again, as humans, as well as in other parts of the animal kingdom, it's a basic requirement of life. In the ICU, most of our communication tends to be verbal or oral, but again, there's a number of reasons why communication, or that active exchange of information, may be disrupted or is impossible. And we're going to talk about some of the barriers to communication and a few of the ways that we can possibly improve our communication with patients. Unfortunately, communication is one of those traits, or many people would argue skills, that people consider to be innate. And going through medical school, we have a lot of time spent on learning biology and physiology and anatomy, and very rarely do you ever actually get exposed to communication skills and how we should be communicating with patients and families. Oftentimes people mistake sympathy for empathy, and again, there is a big difference between the two. As I've mentioned, again, the same does not apply to the nursing literature as it does to the medical literature. And if you look around, really newly qualified as well as senior physicians are really unprepared, and they're unprepared to communicate in a number of senses, specifically with regards to breaking bad news. And I'm not going to spend too much time on that, because that's really a whole topic on its own. We're also not very good at dealing with distraught relatives. It makes many physicians feel uncomfortable, and it's very easy to hide behind technical and medical jargon, or to sort of run off to another consultation or a meeting. And then, of course, providing simple and understandable explanations. And this has been demonstrated in multiple studies. If you actually look at studies looking at informed consent, and as surgeons we're providing informed consent, or so-called informed consent, to patients all the time, more than 50% of patients or substitute decision makers cannot tell you what the risks are, what the benefits are, what the alternatives are, why we're doing the procedure. So there's so many sort of facets of ICU and surgical care in terms of communication that we can improve upon. When we actually look at problems in terms of the ICU specifically with regards to communication, there's a number of large categories. Patient and family anxiety. Again, I mean, most admissions to the ICU are sudden and acute, and so patients or their families find themselves in very unfamiliar and intimidating surroundings. There's a lot of machines, monitors, beeps and lines. The severity of illness. Again, if patients are in our SI, it's usually not because they're well. They're oftentimes the sickest patients in the hospital. And again, there's a complete loss of routine. Altered mental status of the patient is another huge factor that contributes to difficulties in terms of communication. Again, administration of sedative agents, which is a necessary part of being intubated and ventilated, but disease processes themselves, such as sepsis, that result in encephalopathy very commonly. There's a number of barriers to verbal communication, and again, endotracheal tube insertion, and again, the disease process, as well as lack of time. You know, for any of you that have been traveling in foreign countries who don't speak the language, you know how frustrating it can be when you're trying to find a washroom and you really need to go. We have all kinds of mannerisms and ways of being able to explain what we need to do, but imagine being intubated and ventilated. You can't speak. Oftentimes you're restrained, you're on medications, and so it can become very, very difficult. And what are the problems with this? Well, there's a number of problems. Number one, the inability to communicate can lead to a number of issues such as anger, emotional pain. It's not uncommon for patients to describe feeling tortured during their stay in the ICU. And I'm going to talk just a little bit about the post-ICU syndrome, which has been receiving quite a bit more attention in the ICU literature. Anxiety, depression, and the so-called ICU psychosis, which is a form of organic brain syndrome. It's been described in many ways since the 1950s, and really in the past couple of years has been more and more research. But our actual patient Obi, is a perfect example of someone who probably sustained a post-ICU syndrome. Depression, anxiety, PTSD. She was diagnosed with an acute stress disorder by the psychiatry team. So in terms of improving communication, so why should we do it? Because there's pretty good literature demonstrating that can lead to improved physical outcomes with earlier discharge from the ICU, improved psychological outcomes, and again, limiting or preventing the so-called ICU syndrome. In terms of various techniques, we have both verbal and nonverbal. And when you look at studies in the ICU or evidence-based sort of protocols looking at what specific facets or aspects of communication are key, 3 commonly recurring themes come up. One of them is empathic communication, really trying to identify with your patients and their families with regards to their response to injury as well as illness. 2 is sharing prognostic information. And again, there's a lot of literature looking at this. We are very poor at prognosticating. If you look at TBI literature, for example, it's a 50-50. You might as well toss a coin in terms of trying to decide or determine what the patient's outcome is going to be. And patients' families know that, but they still want to know because it gives them time to help to prepare emotionally, financially for possible death of a loved one, and helps them to become part of the decision-making process. And that's really one of the third sort of key aspects of improving our verbal communication techniques, is to really work towards more of a shared decision-making process with substitute decision makers, patients, and their families. Again, nonverbal communication is equally important, and it's oftentimes overlooked, especially when there's a bit of a discord or incongruence between the verbal and nonverbal communication. Patients and families are very quick to pick up on this, and they're very sensitive to it. And again, oftentimes we forget that touch is a very powerful and expressive means of communication. It can signal acceptance, lack of judgment, and is another important means of communicating with our patients. In terms of strategies for improving communication, this is just a list of 10. This again is more geared towards physicians, but I think all of us can benefit from some of these. Number 1, identifying yourself to patients and their families. How often have you seen us come on rounds? The group comes into the bedside, patients' families sitting there, and the junior resident starts, "This is Zebra 2, came in last night, hit by a car," without even introducing who we are, what our role is, why we're there, etc. Being honest and telling the truth is always a good principle. Dressing appropriately is certainly an important thing as well. Making time. One of the other areas or important sort of fields which I feel that we can really improve upon is rounds. There again, there is evidence showing that if conducted in a thoughtful manner at the bedside with patients or their families involved, this can be a great strategy for improving communication. It not only increases patient and family knowledge in terms of what's going on, but it leads to a feeling of reassurance, and it can also help encourage feelings of interest. Looking at sort of rounds held outside patients' rooms in cubicles or in patient conference rooms, it's been demonstrated that it's been much more beneficial to actually hold rounds at the bedsides. And again, I think looking around, that's something that oftentimes we won't do. We sort of stand outside the closed door, talk about patients, and then hurry along on our way. So in terms of take-home points, I think it's really important that, and I know you guys are great at it, and again, I'm really specifically targeting physicians, we really need to encourage house staff to communicate with patients and their loved ones. Again, time is short, and that's why we have private rooms, and we can make appointments with patients and their families later on in the day after rounds to go over important issues of concern. think it's really important not to confuse sympathy with empathy. And again, constructive feedback as well as positive reinforcements for those physicians and healthcare professionals that are doing a good job is always welcome and should be encouraged. Thank you.